Diagnosing death. Neurologic and cardiopulmonary criteria, in adults. Before continuing, please read the disclaimer in the description. A fact of life is that if you are born, your life will end, no matter who you are. We are all pre-cadavers. In the healthcare field, we have the honor and opportunity to witness and accompany patients at different facets of the life, including death.
Why do we need to declare death? Well, there are multiple reasons that include social, legal, medical care, and organ donation. In the United States, the 1980s Uniform Determination of Death Act states that a person is dead by either the irreversible cessation of the circulatory and respiratory functions, or the irreversible cessation of the function of the brain.
So, it has become that brain death, or neurologic death, or the irreversible loss of brainstem functions, as determined by the licensed physician. Typically, a neurologist, a neurosurgeon, an intensivist, a trauma surgeon.
In another perspective, death is regarded as the irreversible loss of the capacity for consciousness, combined with the irreversible capacity to breathe. Brain death does not exist in nature, and the state of a perfused cadaver can only be maintained when artificially supported.
Since a detailed examination for the declaration of brain death is part of the clinical evaluation of the patient, it does not require special consent. It can proceed under the umbrella of implied consent. It is important to document in the note that family has been notified, or how many attempts to contact the family were made. The diagnosis of neurologic death is required for heart-beating organ donation. And the diagnosis of cardiopulmonary death is required for donation after cardiac death.
Most people that die will not need to have a diagnosis of brain death, and it is not required for withdrawal of support, and to proceed to a comfort care-only approach. It is important to maintain the trust of the public and colleagues. For that reason, the diagnosing physician shall not participate in the procedure for organ or tissue procurement or transplantation.
Once the physician has determined that there is severe and irreversible brain injury, several steps or stages are taken in a sequential and organized fashion. It is excluded from the picture that there is no hypotension, defined as a systolic blood pressure less than 100, that there's no hypoxia, no hypoglycemia. Some of those patients may develop diabetes insipidus. There are no extreme intake and output imbalances, in which case optimize volemia, which may require EDH and free water, that there is no locked-in state, examined by passively opening both eyes, and asking the patient to look to the right, look to the left, look up, and look down. If the eyeballs move, then the examination of brain death cannot continue. We exclude that there is no high cervical spine trauma, as it may interfere with the diaphragm function, no severe facial trauma that may interfere with the brainstem exam, that there are no neuromuscular blockers on board, that the effects of sedatives have dissipated. Exclude that there is no poisoning, and that there are no acute severe metabolic or endocrine imbalances. For example, there is no severe hypothyroidism.
The examination is carried in an organized descending fashion from the brain down to the medulla, following the pattern CBA, coma, brainstem, and apnea.
Coma is typically examined by using the Glasgow Coma Score, which should be 3 or 2T. The Glasgow Coma Score assesses the function of both cerebral hemispheres and the upper brainstem. If family members are going to be present during the exam, alert them that spontaneous movements can occur even if the patient is dead. The use of the train of 4, finding it to be 4 of 4, helps document the absence, or significant effect of neuromuscular blockers.
If the patient is in a coma, the next step is to begin the examination of the brainstem from the top down. The pupils should be in mid-position to dilated, and non-reactive to direct and consensual light stimulation. There are no inducible or spontaneous eyeball movements. No eyeball movements are induced by the passive deviation of the neck in the horizontal and vertical planes. Another option, that examines the same anatomic pathways, is to infuse 30 to 50 milliliters of iced water in the intact external ear canal, using a large-bore non-metallic catheter. With the eyelids on both sides open, the infusion of iced water should last for about 1 minute, and there should be a wait of about 5 minutes in between each side. Any eyeball movement implies some function of the brainstem.
There is no corneal reflex on both sides, there is no jowl reflex, there's no cough or gag reflex, and there is no swallowing, yawning, or grimacing.
If after this point, no brainstem function has been detected, then proceed to perform the apnea test. We will be testing the function of the lower medulla. The ventilation is adjusted to reach a normal carbon dioxide blood level just prior to the beginning of the apnea test. The patient is hyperoxygenated, with 100% oxygen. An ABG just prior to the apnea test enhances clinical transparency.
Prior to the disconnection from the ventilator, set the blood pressure cuff to take the blood pressure every 2 to 3 minutes, if there is no intravascular blood pressure device. Also have the oxygen alarm of the ICU monitor on, to be able to monitor cardiac frequency and oxygen saturation level. As the carbon dioxide increases, and with that, the respiratory acidemia, the effect of catecholamines is going to decrease, and the blood pressure may drop below 90. Anticipate this, and be ready to support the blood pressure with intravenous pressor medications. It is suggested that the patient have oxygen in the airway during the entirety of the test. One way of doing this is to insert a catheter via the endotracheal tube with 6 liters of oxygen per minute at the level of the carina. Once the patient is disconnected from the ventilator, then the time is being measured minute by minute. In general, the carbon dioxide will increase 2 to 3 points per minute of apnea. So at the fast rate of 3, it will take about 7 minutes to increase the carbon dioxide 20 or more points, and at a slower rate of 2, it would take about 10 minutes. As long as the patient is not hypoxic nor hypotensive, consider checking the ABG while the patient is still not connected to the ventilator. The person that will be getting the ABGs is ready and has all the equipment at hand, at the bedside. During the entire apnea test, the physician is monitoring the only gown chest and the abdomen of the patient for clinical evidence of breathing. Sometimes, spontaneous movement of the patient can be confused with voluntary activity. Experience in performing this test helps discern any sign of hemodynamic instability or hypoxia, prompts stopping the test, and initiates attempts at correcting the issues.
The diagnosis of brain death is clinical in more than 95% of all cases. Sometimes, other tests are needed. If we think of this entire process as a puzzle being put together, most of the puzzle pieces are in place but 1 or 2 may be missing, and that is when the confirmatory tests are used. For example, if the patient is a chronic carbon dioxide retainer, and all the prior other elements have met criteria, but the normal carbon dioxide in blood cannot be achieved, then one of these tests can be used. There are 2 types: test of cerebral blood flow, or electrical.
If either one of the 2 types of tests meets criteria for brain death, then the puzzle would be completed and the patient can be declared dead. No confirmatory test will supersede the clinical criteria.
In this transcranial Doppler sample of the left MCA, the intracranial pressure is so high that when the heart tries to pump blood into the brain, that the blood refluxes back out of the brain into the carotid artery, with the area under the curve being 0. There are certain criteria for the use of transcranial Doppler in this context.
In the nuclear medicine test, a short half-life gamma emitter solution is injected intravenously into the patient, and wherever the gamma emitter circulates, then the camera detects it. But, if there's no blood flow in a certain part, then the gamma emitter cannot get into the part of the body and there is therefore no gamma emission. In this sample, the gamma emitter could not perfuse into the brain, leading to an empty brain sign.
Some have tried to use cerebral CT angiography. In this example of the same patient, the patient had a CT angiogram initially that documented the presence of blood vessels in the brain outlined by the contrast. Later, the patient deteriorated, and the repeat CT angiogram showed the contrast in the arteries outside the brain but not in the brain. The natural and more common way of death is the cardiopulmonary route. In this, 4 sequential criteria are outlined.
First, the body temperature is equal or greater than 32.2 degrees Celsius. A neurologic examination shows Glasgow Coma score to be 3. There are no volitional motor activity, or responses to verbal or noxious stimulations, there's no pupillary reflexes, and there are no corneal reflexes.
Then, the examination of the cardiac and pulmonary function. Documenting 2 continuous minutes of pulselessness, or 2 minutes of cardiac standstill on ultrasound, or 3 minutes of electromechanical dissociation or asystole in 2 or more EKG leads, and 2 continuous minutes, which can overlap with a cardiac examination, of lack of thoracic and abdominal breathing or lack of breath sounds on auscultation.
There are definitely other signs of lifelessness. Some of them include rigor mortis, dependent lividity, decapitation, etc. These cases would not need to meet the criteria neurologic or cardiopulmonary death to be declared.
Generally, brain death is the path for organ donation. But, via donation after cardiac death, or DCD, organ donation can also occur via the cardiopulmonary route. Both routes can lead to tissue donation.
It is important to know when to call the local organ procurement organization or OPO. The 2 main criteria are when the patient is intubated on mechanical ventilation, and the Glasgow coma score is 5 or less. Also, they should be called whenever death is imminent. The elaborate, multidisciplinary, multi-institutional process of organ and tissue donation can be intense and complex. It is important to call early. For it to be successful, and be able to help and honor donor and recipients, the close and respectful collaborations of the medical teams and the OPO is imperative. The OPO will not be approaching the family at this stage, but will be gathering data from the medical record. The OPO will approach the family after discussing with the medical team.
It is important to remember that the medical team approaches the family about the diagnosis of death. But the OPO will approach the family about organ donation. The approach for organ donation could be done in conjunction with the medical team. The medical team refrains from mentioning about organ donation.
The Code of Federal Regulation revised in 2003 states that the individual designated by the hospital to initiate the request to the family must be an organ procurement representative or designated requester.
Links to some bibliography are found in the description. Thank you.